now we are going to discuss from biliary system small three chapters, three topics. They are choledochal cyst. So choledochal cyst. Second is extrahepatic biliary atresia. 3 is primary sclerosing cholangitis. These are the 3 topics I am going to discuss now. So you can ask, sir, why are you comparing these 3? That is, they are totally different topics, but for understanding purpose and for learning purpose, I used to make some topics as table column, and that is the reason I have made this as a table column. So please remember now, I am going to tell 5 differences between these 3, 5 points between these 3. So when you read by comparing or putting tables like this, you can remember the topic for a long period. For example, if I take only choledochal cyst, followed by only extrahepatic biliary atresia, followed by primary sclerosing cholangitis, you may feel something monotonous. So if I make a table column like this, and if I make comparison, you will never forget these topics for your lifetime. Okay. The first point in this is, first is introduction of these 3 topics. Number 1, introduction. So please remember, choledochal cyst means abnormal dilatation of bile duct. It is abnormal dilatation of bile duct is known as choledochal cyst. So the bile duct is normally 6 mm diameter. If it is abnormally dilated, it is known as choledochal cyst. In pediatric age group, the diameter varies and the diameter is increased in pediatric age group. So choledochal cyst is abnormal dilatation of bile duct, and the most common age group of choledochal cyst is infants. Common among infants, common among female infants, female child. Okay, female child is common. What is extrahepatic biliary atresia? Extrahepatic biliary atresia means inside the liver the bile ducts are normal, but once it comes out, the bile duct is atresia like this. So inside the liver bile ducts are normal. Extrahepatic, outside the liver the bile ducts are atresia. So that is extrahepatic biliary atresia, EHBA. Outside the liver the bile duct is atresia. So this is most common in newborn, and there is equal in male and female. There is no sexual prediction. So it is equal in male and female, EHBA. Primary sclerosing cholangitis, what is it? It is an abnormal dilatation and stricture of bile duct. It is dilatation as well as stricture of bile duct like this. There is a sclerosing nature of bile duct. Therefore, there is dilatation stricture like this is seen in the bile duct. Bile duct stricture and dilatation is known as primary sclerosing cholangitis. It is most common in 40 years and most common in men. It is more common in men. So this is the first difference. Now you can understand how it is easy. So if I discuss all together, comparing one over the other, it is easy to remember. Choledochal cyst means abnormal dilatation. EHBA means atresia outside the bile duct. Primary sclerosing cholangitis means sclerosing with the dilatation of the bile duct. So each one you can find out. Choledochal cyst common in females, EHBA equal in male and females. Primary sclerosing cholangitis is more common among males. And now coming to the clinical features of these diseases. Clinical features of these diseases. So clinical feature of choledochal cyst is characterized by a triad of choledochal cyst known as pain, jaundice, mass. This is a triad of choledochal cyst. Though not commonly seen, this is a triad. Pain, jaundice, mass is a triad of choledochal cyst. What is the clinical feature of extrahepatic biliary atresia? They will also have jaundice and they will have itching all over the body. Because of severe jaundice, the babies may have itching and the babies may have cholangitis. The babies may develop cholangitis. So jaundice, itching, cholangitis are the feature of both EHBA as well as the same jaundice, itching and cholangitis is also seen in primary sclerosing cholangitis. So anyhow, please remember all these guys will develop obstructive jaundice. All these guys will develop obstructive jaundice. Okay. Now coming to the complications. Why should we worry about these 3 diseases? Because the complication of choledochal cyst is it can form stones, it can form cirrhosis in the liver, it can form portal vein thrombosis. The portal vein can get thrombosed in those cases. Cirrhosis can happen, stones can happen, and cholangitis can happen. Since there is obstructive jaundice, there is cholangitis can also happen. What else will happen in these cases? Very, very high risk. We are very much worried because of the malignant risk in choledochal cyst. So malignant risk is there. Malignant risk is there in choledochal cyst. They can develop cancer in the gallbladder, bile duct, pancreas, and liver. In all these places they can develop malignancy. Please don't forget, they can develop malignancy in all these places. They can develop malignancy in all these places. So this is a very important point you should not forget. So the complications of choledochal cyst is stones, cirrhosis, portal vein thrombosis, cholangitis and malignant risk. The malignant risk is more common on the posterior wall of cyst. On the posterior wall of cyst. Most common on the posterior wall of cyst. Okay. And coming to the complications of EHBA. What is the complication of EHBA? Because of the young babies, small thin babies getting obstructive jaundice, they will go for cholangitis and gradually they go for secondary cirrhosis of the liver. Cirrhosis of the liver. So cholangitis and cirrhosis are the 2 important complications of EHBA. And what is the complication of primary sclerosing cholangitis? Very, very dangerous complication is there in primary sclerosing cholangitis known as cholangiocarcinoma. So 10% of these patients will develop cholangiocarcinoma every year. So yearly 10% of them will develop cholangiocancer in primary sclerosing cholangitis. So please don't forget the complications. So I'm going step by step. Choledochal cyst, extrahepatic biliary atresia, primary sclerosing cholangitis. Choledochal cyst common in females, EHBA equal in male and female, primary sclerosing cholangitis common in men. All of them present to you with jaundice and all of them have their own list of complications. And among this, the choledochal cyst has malignant risk and primary sclerosing cholangitis has malignant risk. Okay, please don't forget these points. And now I'm going to discuss the classification of these diseases. So choledochal cyst, there is a classification. Can you tell me what is the name of the classification? The classification is known as Todani classification, also known as Alonso classification. It is a repeat question. Todani or Alonso classification is a classification of choledochal cyst. There are totally 5 types according to this classification. Type 1 is fusiform dilatation of the cyst like this. So this is type 1, fusiform dilatation of the bile duct. Fusiform dilatation of the bile duct is type 1. Type 2 is there is a diverticulum in the bile duct like this, is known as type 2. So type 1 is fusiform dilatation, type 2 is a diverticulum, type 3 is a diverticulum near the ampulla like this. Near the ampulla like this is known as 3, that is also known as choledococele. Type 3 is also known as choledococele. So in this 3, please remember the most common type is type 1 and the least common type is type 3. So there are totally 5 types of choledochal cyst. Type 1 is the most common, fusiform dilatation. Least common is choledacocele, which is a diverticulum near the ampulla. Please remember, there is a diverticulum near the ampulla. And 2 is diverticulum in the bile duct like this. So these are all the cysts. These are all choledactyl cysts, which are all pre-malignant. Type 4, what is type 4? Type 4 is divided into 4A, 4B. In 4A, A for all ducts dilated. All ducts are dilated. Intrahepatic, extrahepatic, all ducts dilated. 4B, extrahepatic ducts only involved. That is dilated. So 4A is all ducts dilated. 4B is extrahepatic duct dilated. 5 is Caroli disease. What is Caroli's disease? So Caroli's disease is a condition in which multiple intrahepatic duct dilatation like this. It looks like a polycystic liver. It looks like a polycystic liver. There will be multiple intrahepatic cystic dilatation seen. That is known as Caroli's disease. It is intrahepatic duct involvement. Extrahepatic will be normal, only intrahepatic duct involvement. So this is the classification of given by Todani or Alonso. So please don't forget the 5 types of choledactyl cyst. And coming to extrahepatic biliary atresia. Extrahepatic biliary atresia, there are 3 types. So type 1, the atresia is seen at the level of bile duct like this. This is type 1. Atresia is at the level of bile duct, so the gallbladder is enlarged. In type 2, the atresia is at the level of common hepatic duct, so gallbladder not seen. And type 3, the atresia is at the level of porta hepatis. At the level of porta hepatis. Now tell me which is common type. So there are 3 types. Type 1 at the level of common bile duct. Type 2 at the level of common hepatic duct. Type 3 at the level of porta hepatis. So the most common, in otherwise 90% of the cases are type 3 extrahepatic biliary atresia. Exactly at the portal hilum, there is full atresia, that is type 3. Type 3, there is complete atresia seen. Okay, these are the 3 types of EHBA. Primary sclerosing cholangitis is of 2 types. Primary sclerosing cholangitis of unknown etiology. Please remember, of unknown etiology. No etiology known. Probably they are associated with HLA and they can be associated with Riedl's thyroiditis. Riedl's thyroiditis may be associated with them, or there may be associated de Quervain's disease. So primary sclerosing cholangitis is of unknown etiology. And all of you know very well, secondary type of primary sclerosing cholangitis is associated with what disease? Ulcerative colitis and Crohn's disease. Which is common of the 2? The common type is, secondary type is most common. Please don't forget this classifications. So classification of choledactyl cyst, EHBA and primary sclerosing cholangitis. What is the most common type of choledactyl cyst? Type 1 is the most common type. Fusiform dilatation. Most common type of EHBA, it is type 3, in which the atresia is at the level of porta hepatis. The most common type of primary sclerosing cholangitis is secondary, that is associated with ulcerative colitis and Crohn's disease. Now coming to the investigations. Investigations of these 3 diseases. Investigation of choice to diagnose choledactyl cyst is what? By MRCP is the investigation of choice to diagnose. Caroli's disease on CT scan shows a sign. What is the sign? That is known as central dot sign. Central dot sign is a sign shown on CT scan in Caroli's disease. That central dot is nothing but portal vein radical. The portal vein radical appear as central bright spot. So investigation of choice to diagnose choledactyl cyst is MRCP. Investigation of choice to diagnose EHBA is what? So this is highly controversial, but the controversy is cleared by Sabiston. Sabiston says the best answer is liver biopsy now. Investigation of choice to diagnose or the gold standard investigation. Both are liver biopsy now for EHBA. So before doing anything on a EHBA, take a liver biopsy and confirm there is excessive bile duct proliferation in the biopsy. The biopsy will show excessive bile ductular proliferation. Okay, so therefore liver biopsy is the gold standard investigation to diagnose EHBA. Ultrasound of EHBA will show you a sign known as, what is the sign? A sign known as triangular cot sign. Triangular cot sign can be seen on ultrasound in a EHBA patient. What is the investigation of choice to diagnose primary sclerosing cholangitis? Can you tell me? Primary sclerosing cholangitis investigation of choice to diagnosis by ERCP. ERCP will show you the beaded appearance of intrahepatic ducts like this. And this appearance is known as prune tree appearance. Prune tree appearance or beaded appearance. That is known as prune tree appearance or beaded appearance in a ERCP. So investigation of choice to diagnose choledactyl cyst is by MRCP. To diagnose EHBA is by liver biopsy. Primary sclerosing cholangitis is by ERCP. So MRCP, liver biopsy, ERCP. These are all taken from Sabiston. So no controversy, no confusion at all. Okay. And finally coming to the management of all these diseases. So you can understand one important reason why I am discussing all these together is, in all these cases, 1, 2, 3, there will be one option at the end, that is liver transplantation. Liver transplantation is an indication for all these cases. In all these cases, there will be one indication, liver transplant. But let me discuss each one separately now. First, we will discuss choledactyl cyst. Let us discuss choledactyl cyst. Please remember, choledactyl cyst is a pre-malignant cyst. The points are, it is pre-malignant cyst. And they have recently found out this is due to anomalous pancreatic bile duct junction. So choledactyl cyst is usually associated with anomalous pancreatic bile duct junction. The bile duct and pancreatic duct joining, there is some anomaly. That is the reason the pancreatic juice reflexes into the bile duct and resulted in this problem. So this is a recent advance. Recently they found out choledactyl cyst is due to anomalous pancreatic bile duct junction, and they advise resection for all cysts. The cyst must be resected. Why? Because it is pre-malignant. So we must resect any cyst. Any choledactyl cyst should be resected. Please remember this. So therefore for type 1, this is fusiform dilatation, and for type 2, this is diverticulum in the bile duct. In both the cases, you can very well see I am resecting the cyst and removing it out. I am removing it out, and I will bring a jejunum and anastomose like this. So hepaticojejunostomy will be done for type 1 and type 2 choledactyl cyst. After resecting the cyst, I will do hepaticojejunostomy. Type 3 is a diverticulum near the ampulla. So what I will do here is, very rare type, but the treatment is transduodenal sphincteroplasty. Transduodenal sphincteroplasty should be done. You have to go and do a transduodenal sphincteroplasty is advised for 3. And 4 and 5, as I already told you, 4 will have multiple cysts. 4 and 5, both cases, the treatment is liver transplantation. So please don't forget choledactyl cyst management. 1 and 2, we resect them and do hepaticojejunostomy. 3, we do transduodenal sphincteroplasty. 4 and 5, we advise liver transplantation. What is Lilly procedure? In choledochal cyst, what is Lilly procedure? Lilly procedure is a procedure in which if the posterior wall of the cyst, very much closely attached with the portal vein, what we do is we remove only the anterior wall. The anterior wall alone will be removed out like this, and the posterior wall, we leave the serosa there itself and we core out the mucosa. We remove the mucosa will be removed. So we'll leave the posterior wall there itself and remove the mucosa alone. This is known as Lilly procedure. So Lilly procedure is anterior wall is removed, remove the posterior wall mucosa and leave the serocell with the portal vein itself, because the portal vein and the cyst are very closely attached. This is very rarely done procedure. Just for completion, I'm telling Lilly procedure. Okay, just for completion, I'm telling Lilly procedure. So this is the management of choledochal cyst. Coming to management of extrahepatic biliary atresia. In a very small baby, extrahepatic biliary atresia, the baby is brought by the mother with severe jaundice. So as soon as I see these babies, I should plan for a portoenterostomy. This is porta hepatis plate, the hilar plate. I will core this out and bring a jejunum and anastomose with this portal plate. There will be microductules which will drain now into this, and this is known as portoenterostomy of, what is the name of the procedure? Portoenterostomy procedure known as Kasai procedure. Repeat MCQ 100 times asked question. Kasai procedure is a procedure done for EHBA. This is a time buying procedure. Please remember, this is only a bridging procedure. This is only a bridging procedure because this will temporarily help the patient. In gradual time, all the intrahepatic duct also will get atresia and the patient will go for cirrhosis. Therefore, within a period of time, we should arrange liver transplantation. So the gold standard treatment for EHBA is liver transplantation. Please remember, the gold standard treatment is liver transplantation. So initial time buying procedure is bridging procedure is Kasai procedure. At this point of time, I would like to tell you some of the prognostic factors after Kasai procedure. What are all good prognostic factors after Kasai procedure? If you operate the baby less than 6 weeks, it is good prognosis. And size of ductules, the microductules in the hilum, if they are more than 150 microns, it is good prognosis. No cirrhosis, it is good prognosis. There is no cholangitis, that is also good prognosis. So what are all good prognostic factors after Kasai procedure means surgery done before 6 weeks, size of ductules more than 150 microns, there is no cirrhosis in the remaining liver and no cholangitis in the patient are all good prognostic factors. Please remember these are all the points you should not forget in Kasai procedure. And what is the management of primary sclerosing cholangitis? They are going to develop 10% per year, they are going to develop cholangiocarcinoma. 10% per year will develop cholangiocancer. Therefore, the only treatment available is liver transplantation for them. So please remember, we have to do liver transplantation, otherwise most of them will die in these cases. So please don't forget, liver transplantation should be done for these patients. Let me show you the images of this chapter now. So choledochal cyst, what is the name of the classification? Todani classification or Alonso classification. You can see type 1 is fusiform dilated cyst. Type 2 is diverticulum. Please don't forget these two types. This is diverticulum, this is fusiform dilatation. So most common is type 1, least common is here in which there is a diverticulum near the duodenum. 4A means all ducts dilated. B means extrahepatic dilatation. 5 means Caroli's disease. Multiple cyst in the liver known as Caroli's disease. 5. You can see this is one of the patient with a fusiform dilated choledochal cyst. We are completely removing the cyst along with the gallbladder. So this is a treatment and we do a hepaticojejunostomy. So this is a CT scan of a Caroli's disease. Multiple cyst with, there is a portal vein radical known as central dot sign. Please don't forget central dot sign. Okay, central dot sign. So please don't forget the treatment of choledochal cyst. Coming to extrahepatic biliary atresia, these are the types. Type 1 in which the common hepatic duct obstructed. Type 1 common bile duct obstruction. Type 2 common hepatic level, there is obstruction. Type 3 there is obstruction at the level of porta hepatis. So this is the most common type. Please don't forget that is the most common type. 90%. So this is a typical picture showing you extrahepatic biliary atresia. This is a specimen of a patient. So this is a triangular cord sign. So what is the investigation of choice for this liver biopsy? Liver biopsy is the investigation of choice. Okay. So please don't forget that point. In extrahepatic biliary atresia, this is Kasai procedure. High yield MCQ topic. Please don't forget Kasai procedure. So coming to primary sclerosing cholangitis, it's more commonly seen in ulcerative colitis and Crohn's disease, and this is how there will be onion skin sclerosing of the bile duct. And the picture will show you prune tree or beaded tree appearance on ERCP, the investigation of choice. Investigation of choice is ERCP, that will show you prune tree or beaded tree appearance. Prune tree or beaded tree appearance is seen. And for all these cases, please remember liver transplantation is the last treatment. Okay. So please don't forget the various points of these three rare diseases. You can get these diseases in exams. Okay.